I'm Allison Agu, Professor of Adult and Peds ID and the Director of the JH Wiki. We are so excited to have you join us for our virtual toolkit series, where, as you know, the goal is to engage and amplify. Next slide, Marinas. So briefly, if this is your first time attending, our JHM Wiki stands for it's a Johns Hopkins Medicine collaboration with women, infant, children, and youth for HIV excellence across Central Maryland. And we are comprised with 6 programs, including the Johns Hopkins Pediatric Adolescent Young Adult AIDS Program, the Women's Health Program, Sinai Supportive Service, as well as the University of Maryland's HIV program, our Hopkins Emerge, and a Hopkins Psychiatry program. And the idea is for us to have a more coordinated response to HIV care by establishing these mutually beneficial relationships that increase the quality of care across our community. And the mission is to build upon the structures that we have to create a more dedicated network of providers who are engaging and amplifying. So we're experts, but we're all experts, and we really do want to hear from you. I want to acknowledge our funders, which is HRSA, and our grant number below. Next slide. But today, we pride ourselves, the Wiki Toolkit, about having novel conversations, different conversations, and today it's an infrequent conversation. So excited to have a friend and colleague, Dr. DeVonnia Bonimy-Lee, who has many letters, DPT, WCS, CLT. She's a licensed doctor of physical therapy for over 17 years in both New York and the Bahamas, with expertise in women's health rehabilitation, inclusive of prenatal, postpartum, musculoskeletal dysfunction, lymphedema management, and cancer rehabilitation. She's American Board of Physical Therapy certified and has many subspecialties, particularly in certified lymphedema therapy and hatha yoga instructor. She specializes in the care of cancer survivors, dedicated to helping patients manage long-term physical effects of cancer treatment, including but not limited to lymphedema and radiation-induced fibrosis in skin and soft tissues. I didn't say this to you, Dr. Bonimy-Lee, but I thought about this when I met you because I had a young woman who had been living with HIV who had really a cancer and had irradiation of her pelvic area and had a lot of pain. And so when I met you, I thought this is something relevant as people are aging with HIV and developing comorbidities, but it's something that we oftentimes don't talk about. So really excited to talk to you and have you talk to us about this. And not just for women, for men as well, and across the gender spectrum. Excited to hear you here. So I think a couple things. She's passionate about patient advocacy, and that advocacy is around pelvic floor dysfunction, chronic pelvic pain, defecation disorders, musculoskeletal impairments, all of it, and survivors of all kinds, perimenopausal cancer and the like. So with that, I'm going to pass it over to you, Dr. Bonimy-Lee, to really tell us about this exciting conversation and infrequent conversation about pelvic health. Over to you.
Okay, great. Thank you so much for having me. This is a very unique experience, and it's been wonderful sort of meeting you, Dr. Agua, and being able to share the knowledge I have for the passion of pelvic health. I still have a little screen here. I have a thing here where it says meetings being recorded, but I can't seem to get it off my screen. Do we know why it won't come off? I'm not sure what happened there.
You have the OK button. Just hit OK. And
it just keeps, you don't see it at all then, do you?
No.
Oh, okay. Yeah, my cursor's gone and everything. Okay. Well, we'll just start then. The role of pelvic health in optimizing. Let me see if I can. Yeah.
I think someone's unmuted. If you could please mute.
Okay. All right. So the recording is just staying on my screen. I'll try and read around it and hopefully it's going to be fine. Unless I can, we'll just see how it goes. So the role of pelvic health in optimizing women's health. This is a discussion. So I like that it's under the topic of infrequent conversations, because we don't have our village of support like we used to when it comes to women's health. And the discussions that women used to share with their younger generation, those conversations aren't happening as often as they used to. We've kind of lost a little bit of our village. So I hope to be able to bring this topic to you. We're going to look at the next slide here. So, Dr. I kind of introduced, there are a lot of letters behind my name. Just a quick reminder, if you can, please mute. But yes, I'm an American board physical therapy specialist in women's health and sat for the specializations for the boards. I'm also the president, or was the immediate past president of the Bahamas Association of Physical Therapists for the last 2 terms. And I've been a therapist for about 17 and a half years. This is my business, Viva Physio and Wellness. So I'm happy to be able to share this passion with all of you. When we think about the objectives, we're understanding. I'm going to have to pause. I really can't see most of my screen. I don't know
You
why.
want to stop sharing and then maybe reshare? Maybe that may fix it.
I would, but let's try that. Stop share. Got it.
It's
Okay.
all good. We're
Thank you
very
so much.
informal here, so make sure you can see what you need to see.
I gotta be able to see it.
I know,
Okay.
right? And just a reminder, please, please, please mute yourself. Someone keeps coming off and on mute, and we can't mute you centrally because we're then muting Dr. Bonimy-Lee, which we don't want to do.
Okay, great. Thank you so much. All right, so we're understanding the importance of pelvic health, recognizing common health issues, debunking myths, exploring treatment, all the things while you're here. Just a quick disclaimer that I currently live and work in the Bahamas, so there might be some references or some information where you think, well, is that really applicable to me? Or I may not have the most up-to-date for something when it comes to population and that sort of thing, but bear with me and let's see how we go. And now I can't change the screen. Okay, great. This is a wonderful quote. Communities and countries and ultimately the world are only as strong as the health of their women. And that's true, of course, because we're the ones who are, we curate the lives of our families. We make sure that people go to school, make sure that little people are fed, make sure they go to bed. We also make sure that our loved ones are well taken care of. And ultimately, we are also the storytellers of our history and our generations. So when it comes to pelvic health and it comes to optimizing pelvic health, those stories are very important to share when it comes to both good and bad experiences during the lifespan, as well as during childbirth, and as we go and transition into menopause and older age. I have this picture here, these 2 pictures. I have 2 kids. I've had wonderful experiences with childbirth, but on the bottom left of the screen, you'll see that there are quite a few things that are also possible during the phase of pregnancy. There are lots of different diagnoses that can occur, musculoskeletal, as well as pelvic floor related, that women go through. And we may not have an opportunity to explain or have the vocabulary to talk to our gynecologists, to our obstetricians. But knowing that there are lots of episodes and challenges that women go through, even though a picture may speak 1,000 words, there's so many words that we don't get a chance to communicate. Sometimes things look like everything's going well, but there might be a lot more things going on. So where is your pelvic floor? Both men and women have a pelvic floor, of course. So when we look at the picture on the left, please be aware or orient yourself to where the pelvic bone is. And as you swoop down and under, you see where the coccyx bone is. Between those 2 bones, you have the attachment of the pelvic floor, which is really kind of like a bowl of muscles that really help to support the pelvic organs. Within that space, you'll see the rectum, you see the bladder, you'll see the prostate underneath. You're like, why are we talking about men? Men have a pelvic floor, so we will kind of touch base with their anatomy as well. The urethra is the tube that comes from the bladder and goes through the prostate and then out through the penis. So we're thinking about how urine is coming out of the body. When you think about women, you're also looking at a similar picture here in terms of where is the tailbone, where is the pubic bone, how do these muscles connect, and how they also form and function the support of your pelvic organs. That would be your bladder, your uterus, and your rectum. So the function of your pelvic floor is storage, evacuation, and sexual function. Both men and women, storage, evacuation, and sexual function. All of these things are so important throughout our lifespan. So the importance of pelvic health, right? We talked about what the pelvic floor does, but it matters during childbirth, of course, because we're talking about how are we evacuating this whole new person. The uterus contracts, and then your pelvic floor has to relax to allow for the movement and for this movement of this baby to come to the world. In infancy, we are all learning how to control storage and evacuation. We are learning that through motor milestones, through crawling, through kneeling, through standing, through sitting, through exploration of our environment. We're learning how to control these motor functions, musculoskeletal system. In adolescence, we are all going through sexual changes. We're learning about our identity. We're learning about how our bodies are changing. And so your pelvic health is very critical at this stage, understanding that certain habits have long-term effects based on the things that you do. When we think about how we are training our young children to take care of themselves, understanding self-care, all of this is important when we bring up the discussion of pelvic health. Are we able to have these discussions with our youth? Of course, in adulthood, men and women, we think about. Still hear me? Yes. In adulthood, for both men and women, we're also considering how storage, evacuation, and sexual function continue to matter. And in the postmenopause phase, as we get older, we're also thinking about how we're losing estrogen, how our bodies are changing. There's vaginal dryness, intolerance to penetration, and all of these things can happen at any stage when we're thinking about how we're able to connect with and understand the signals that our bodies are sending. So the overall well-being should be prioritized as we look through the whole life stage when it comes to pelvic health, not just through certain stages. So focusing in a little bit closer on the importance of pelvic health, the three most common conditions, and you can see there are quite a range. I think it was documented something like 200 different disorders that are possible, but the three most common conditions include urinary incontinence, fecal incontinence, and pelvic organ prolapse. When we think about those three, urinary incontinence can also be stress urinary incontinence, which is where you leak urine when you're coughing, laughing, sneezing, jumping, lifting, carrying. Urge incontinence means that when you feel the urge to go to the restroom, that's when you start to leak. More commonly, some people may know it as key indoor syndrome. You are on your way home, you're driving, but as soon as you get to the front door and the key goes in to unlock the door, that's when you start to leak. Many people are familiar with urge incontinence. And then we have urinary frequency, where you're going to the bathroom quite often, maybe every 20 minutes, maybe every 30 minutes. You're unable to empty completely, or you feel as if, your bladder's not allowing you to empty all the way. That's not incontinence, that has to do with frequency, but we'll talk more about that when we get to the pelvic organ prolapse. Fecal incontinence has to do more with fecal smearing, or even where you have a second bowel movement where you thought you were finished. Fecal incontinence can be the result of different experiences during childbirth, ligament laxity, muscle weakness. When you have an episiotomy, or if you have a severe tear within the perineum, you can have significant issues related to getting those muscles to function again, and fecal incontinence can occur even up to 5 years after childbirth. Pelvic organ prolapse, look to the pictures on my right. The top left picture shows you what quote unquote normal anatomy looks like. And we, again, orient ourselves to the pubic bone in the front, the tailbone in the back, and you see the bladder, the uterus, and the rectum in the position they're supposed to be. They're supported by the pelvic floor muscles in the position they're supposed to be. When we look at the prolapse of the rectocele, looking at the picture just below, you can see that there's a pocket that forms, or there's an opening that is there that's not supposed to be there if you compare the picture above. The rectocele is a type of prolapse, whereas if you have someone who is chronically constipated or tends to bear down or hold their breath when they have a bowel movement, you can create this almost pocket that then prevents you from being able to empty. So you may be sitting on the toilet for a long time, waiting or pushing, and nothing comes out. And then you find that you have to manipulate or create pressure to allow for the contents to be evacuated. In the other two pictures, you can also see the anterior or front wall of the pelvic organs. So part of the bladder is also tilted back. And as a result, the uterus also slides in a new position. So when the bladder is tilted, that's called a cystocele. That's a bladder prolapse. When you have a cystocele, you can also have something called a urethrocoele. Urethrocoele means that the urethra, that tube that comes from the bladder that allows for urine evacuation, can be kinked. It can also prevent urine from being able to exit the body completely. You can have backflow of urine or bacteria, which can also cause frequent UTIs. And then the picture at the bottom would be also where you see the uterus itself in the very downward position, almost at the opening of the vagina, where if you were wiping, right, you may feel that there's a bulge there, or you may notice heaviness when you start to go for a jog, or you may notice that it's difficult for you to tolerate a pap smear or intercourse or any sort of vaginal penetration. You may notice that as you have more children, it becomes much more difficult to be able to hold and to support your pelvic organs as a result, and you become more of a high risk because of what's happening with the support and lack of positioning. So up to 50% of women will experience a pelvic organ prolapse in their lifetime. That's pretty significant. I think there are 50 people on this webinar today, and I just want to think if we're all women, if we were all women, half of you would then be experiencing some form of these symptoms that I've just discussed. So the idea of pelvic heaviness, incomplete emptying, difficulty with evacuation, difficulty or pain with intercourse and intimacy, lots of these issues related to inability to maintain physical activity. All of these are a result of pelvic floor dysfunction. I bring up this next point, dysfunctional voiding in children, because what we teach our children is so important in this adolescent period about how we use the restroom and how we take care of ourselves. So in this study, it mentions that they used a group of children between the ages of 5 to 13 without neurologic impairment. And the children had voiding dysfunction, urinary incontinence, pelvic holding maneuvers, and that they were holding all the time. They weren't able to fully evacuate. Voiding difficulties, urinary tract infections, and constipation. And what they found is that constipation seemed to be secondary, or the detrusor instability and this constipation seemed to be secondary to constipation, in that the ability of the bladder lining is the detrusor muscle, the ability of the bladder to effectively contract all the way to allow for the urine to be emptied is secondary to chronic constipation. So someone who is always bearing down, someone who has to rush to use the bathroom and tends to push to empty. Some of us who use our phones in the bathroom, please don't use your phones in the bathroom. You're distracted and you just want to get in and out, or you're afraid to use the bathroom at work or at home or at school. A lot of our habits as adults can be carried over to our children. So it's really important to have those conversations about pelvic health. Hey, how long are you spending in the bathroom? Do you feel like you always have to push? Are you having any issues? Do you feel like it's difficult? And be comfortable having those conversations with our youth. 25% of American women will suffer from pelvic floor disorders. So 1 out of every 4. So think about your girlfriend group. If there are 4 of you, 1 of you will suffer from pelvic floor disorders. So the significance of this and the importance of pelvic health, understanding what your body's going through and being able to have the vocabulary for it is so important. Number of women with urinary incontinence, 60%. So we talked about the different types of incontinence. Yes, you can have urge incontinence or stress incontinence, but you can also have a mix of both. So there are women, walking around every day wearing pads, worrying about where the bathroom is, going just in case. They're training themselves to have this life that's kind of filled with anxiety and stress because they're worried about having an accident. Symptoms of impaired pelvic health. So when you're worried and you want to know if this is something you should talk to your doctor about, yes, you're going to say, okay, I'm leaking, or I'm noticing fecal smearing. I'm noticing when I cough or laugh or sneeze, or when I exercise, there's leakage. Intercourse is painful. I can't tolerate the speculum, even if they use the smallest speculum, even if you have the most gentle gynecologist, right? So being able to tolerate that, this is a medical issue if you cannot have cervical cancer screening, if you're not able to test for your pap smear and check to see what's going on, that's a real medical issue. Protrusion of pelvic organs from the vaginal opening or prolapse, these are all symptoms that you need to speak to your healthcare provider about. So your GP, your primary care physician. I love this slide because it kind of shows you, the question I wanted to put on here was, so when are you going to have surgery? Right? If 1 out of every 4 women is going to have pelvic floor disorder and 50% of us are going to have prolapse symptoms, then, this slide kind of shows us that the one on the left, women who are having surgery, the rates per 10,000 persons per year really significantly increases after the delivery of their first child. So you may deliver at 25, and then by 35, 45, 55, you're planning to have prolapse surgery. That's really significant. And I think this one was from 2007 in terms of when this research was done. When we look at the incidence of the number of women undergoing surgery for pelvic floor dysfunction, the amount of women undergoing surgery in 1 year, 200,000, stress incontinence, 120, and fecal incontinence. And then the last is surgery for stress incontinence. I think that's what that one says. I'm trying to move my mouse. It didn't do that again. But anal sphincter injury is a leading cause because when we have the significant tear that's happening during childbirth, or when we have these obstetric anal injuries and it's not being addressed through their healthcare practitioner, we're really kind of setting ourselves up for needing surgery later, not having the preventative measures in place or the communication in place to prevent worsening of our symptoms. I think we all want to avoid surgery at all costs as we get older. So on to the next objective, common pelvic health issues. We talked about the anatomy, and we talked a little about the pelvic floor issues when we think about continence, incontinence, prolapse, and chronic pelvic pain. Chronic pelvic pain is a whole other world of discussion, so we'll just very briefly touch here. But I show this picture because when you look at the muscles of the pelvis, and this is just some of them, you really have to have a better appreciation for what else is going on in your body. And all of those yellow lines you see there are the nerves that traverse this whole section. So really importantly, it's never just one thing that's going on when you're noticing issues related to incontinence or prolapse or chronic pain. You could have nerve impingement, you could have muscle lengthening, adaptive shortening of the muscle. Many of us are driving and sitting throughout the day. So a lot of our hip flexors, our hamstrings are tight, which pull on the lower back or pull on the ischial tuberosities, which then create shortening of the lower back and lordosis. And then we have these issues related to low back pain, which then causes to change our posture and then increase the risk of prolapse. When we have poor posturing or when we don't have stacking of our spine, we are at higher risk for increasing intra-abdominal pressure. Intra-abdominal pressure meaning that you're more likely to bear down, push down, create a valsalva, and that tends to push all of those pelvic organs further down where we don't want them. We want them supported and up. But think about your everyday posture on the phone, driving, doing everything in front on the computer. Our bodies are now adaptive, shortening. We're shortening each day in the front of our bodies and then creating this downward pressure, which can worsen prolapse. When you have issues with pain, for example, abdominal pain or cramping, or you've had surgery, or you may have issues with rib expansion, maybe you have a chronic cough, all that also, it also increases your risk of having prolapse because you are assuming a pain posture, which then it continues to manifest itself in poor muscle function. Hopefully that made sense the way I said it. When it comes to risk factors, for pelvic floor dysfunction, yes, obesity is a risk factor. Parity, so number of children you've delivered is a risk factor. Age, maternal age is a risk factor as well. Chronic respiratory issues tend to be a factor. If you're always coughing, and we noticed this during COVID, patients who had long COVID had this repetitive cough, we're noticing more issues related to pelvic floor dysfunction. These are all risk factors related to these common pelvic health issues. Finally, postpartum, there's a physical and emotional toll with pelvic health challenges. And this is also sort of my platform to say, why aren't we having more time in this maternity leave, right? So 12 weeks, 13 weeks is never going to be enough time for a new mom, especially a mom who potentially was high risk pregnancy. She was hospitalized for more than a few days. She may be there for a few weeks, does not have the support at home, and then expected to return to work within 12 weeks while she's trying to figure out breastfeeding. When we know that the World Health Organization recommends 6 months of on-demand breastfeeding. We know that pelvic floor dysfunction and prolapse and return to exercise should occur between 3 and 6 months postpartum. And we know that mental health really should take priority in that postpartum year. Why aren't we prioritizing more with maternity leave as they do in other countries? And I'm speaking specifically for the Bahamas, of course. Common pelvic health issues. Hopefully this slide does not offend, but again, reminding you that there are nerves that travel to different parts of the genitalia. And those nerves originate in the lower back. Really, when we think about how the spine is developed and how nerves branch off of that spine, if you have low back pain, there might also be a reason why your pelvic floor dysfunction can be worsening when you're noticing lower back issues. So again, stress incontinence represents 50% of cases of urinary incontinence worldwide and is more prevalent than other types of urinary incontinence in women under 55 years of age. If you think about when you go to different exercise groups, women are now encouraged to do heavier lifting. We're encouraged to do more jumping and landing, better for bone development, bone growth, to stave off the effects of osteopenia and osteoporosis. We then have to still consider, how are we controlling our bodies during all of this exercise and impact? Do we have the strength, considering the rest of our days is set at a computer for most of us, or sitting, are we able to really kind of balance out what our body should be doing? And are these habits that we learned when we were younger, is there also an incidence of hypermobility, ligament laxity, et cetera, that might be contributing to some of these factors too, with stress incontinence? Remember, stress urinary incontinence when you laugh, cough, sneeze, jump, and you notice leakage. Levator muscle damage risk. Talked a little bit about this as well. So other reasons or risk factors can include a long second stage of delivery, labor and delivery. The longer that stage, remember, your uterus is contracting. When women are unsure or unaware of how to relax their pelvic floor and they're fighting against that contraction, it's also creating potential damage for the levator ani muscles, which are most made up of the pelvic floor. When you have this damage, you can have significant tearing as well. Birth weight. So the larger the baby, the bigger the head, the longer the baby's been in their cooking. That's going to be part of the reason why you can also have more levator muscle risk or damage, sorry. Forceps delivery, potentially, and of course, it also mentions posterior occipital birth. So depending on the head position when the baby's being delivered can also put the mother at risk for increased risk of this levator muscle damage. Trauma to the pelvic floor develops into lifelong consequences for women. We talked about the prevalence of surgeries for prolapse, but also those symptoms that women have to deal with for the lifespan are really hindering their ability to engage in the community, to feel comfortable with their friends and be active in terms of their health. And now you have more issues related to non-communicable diseases because women just don't feel comfortable being able to participate, right? Relaxing the levator ani muscles during labor decreases the risk of stretch-related injury. I love that sentence because, first of all, you have to know how to contract as well as relax. Many of us do not even know where our pelvic floor is. And then many of us use just our glutes to do Kegels or to do our pelvic floor contractions. So maybe we're not focusing on the right muscles. So yes, relaxing the levator ani muscles during labor decreases the risk of stretch-related injury. But first, you have to know where these muscles are and have volitional or voluntary control. Anal sphincter injuries increase the risk of fecal incontinence. So the more tearing you have between the perineum, so the vaginal opening and the anal opening, that tear in between there, as well as the levator ani, the muscles behind the vaginal opening, those injuries really increase the risk of fecal incontinence, of urinary incontinence, of the prolapse and sexual dysfunction, because those muscles aren't able to come together the way they're supposed to lift, support, allow for storage, evacuation, and sexual function. In order to have better arousal and better orgasm, those muscles need to be able to contract maximally and relax maximally. And finally, postpartum fecal incontinence has been reported up to 25%. And again, this can happen within the first few weeks or in the first 5 years, patients are seeing fecal incontinence that late in the game of postpartum period. For men, and I don't want to forget about our men, you'll find that yes, pelvic floor or chronic pelvic pain is something that can can be common because we're thinking about pressure on any of those nerves you see in the picture there. So again, the pudendal nerve branches off into 3 different sections. And if you have consistent pressure on those nerves, you can create nerve impingement or nerve damage, depending. So we're thinking about cyclists, we're thinking about people who sit for a long time. Also consider those who have an enlarged prostate and how that pressure relates to how your pelvic floor muscles can function. Following prostate surgery, whether it be for prostate cancer or for a transurethral resection of the prostate, there's going to be an interruption of how your urethra functions, of how your pelvic floor muscles function in communication with your detrusor muscle or the bladder. And relearning some of those skills is going to be important for full erectile function, full evacuation, and full storage function. So debunking myths and reducing stigmas. There are lots of things that people think about their pelvic floor, and there's a lot of things that people don't want to talk about at all. In this setting, as a pelvic health physical therapist, I make sure I create a judgment-free zone because I've heard almost it all. I've heard a lot of things. And it's important that people feel comfortable to communicate what they're going through. Also, it's very important to feel as if, there's no judgment and that it's a safe space to communicate and feel that there is room for help and to have access to resources for you. Seeking care without embarrassment is so critical. And women and men, we really want to be heard by our medical practitioners. So screening and encouraging our healthcare practitioners to screen for pelvic floor disorders, to screen for urinary incontinence, for chronic pelvic pain is so important for our community, in the greater community, and understanding the impact of maternity leave on physical healing and mental health is critical. So we'll do a quick quiz. Question. By now, some of you may know, and you can also raise your hand or have a chat if you wish, but true or false, only women have a pelvic floor. You can unmute for this part, I think. False.
They're dropping it in the chat too.
Pelvic floor dysfunction only affects older adults. False. That's right. Kegels and pelvic floor exercises are only the only solution for pelvic floor problems. False. Thank you for that person who's putting everything in the chat. Tight leggings will weaken your pelvic floor muscles. Let's get back to that. It's pretty much false, but I also want to explain that one. Pelvic floor dysfunction is normal after childbirth.
I'd say false, but it happens, but it should be.
That's a good thing, right? So when we think about it, it's false. It's common, doesn't mean that it's normal, right? So let's make sure we normalize that sentence. Even though it's common, doesn't mean that it's normal. Painful sex is normal.
False.
Exercising while pregnant will harm the baby. I don't know how many of you saw the Olympians doing what they do best, those women who were in the Olympics, pregnant, but exercising while pregnant will not harm your baby. But there are many cultures, many communities who still feel as though exercising is not a great thing to do. Again, that's a conversation you have with your physician, but I will show you a few resources that really support and show the benefits of exercise for both baby and mom. So yes, when it comes to tight leggings and pelvic floor function, really the tight leggings is about how much you're squeezing on this abdominal area, right? When you're squeezing on the abdominal area, you're not letting your abdomen or your rectus abdominis, transversus abdominis muscles do their job. So when you're using things that are squeezing in that area, you're not allowing your muscles, your body to do its job. And so you are less likely to recruit your pelvic floor muscles appropriately during your everyday activities, right? So in our efforts to become snatched, sometimes we do a little bit too much and we don't allow our bodies to do what they're meant to be able to do. So in that respect, tight leggings specifically don't weaken your pelvic floor, but telling your body not to do the job it's meant to do, and as a result, not recruiting the muscles, then that can be certainly detrimental to your pelvic floor strength and function. So stress incontinence, fecal incontinence, and pelvic floor prolapse mean that the people who are experiencing this, 25% of us, 50% of us, we are limiting our social activity, we are limiting our sexual activity, our physical activity, and we're fearful of surgery. So we're going through life with this level of anxiety that some people don't have at all. Sexuality is such an important aspect of our quality of life and is impacted by pregnancy. So all these things happen during pregnancy. Your body's changing, your pelvic floor changes 3 times the length it's supposed to be, and then it's supposed to recoil back. But for some reason, women feel as if they have to run back to work, or we have to rush back to cooking and cleaning. There's so much things that we have to do in those first few weeks. But the postpartum period is really a time of grace, and it's really a time to reset and reconnect with your body again. And that's where I talk about in the beginning, that village that supports us, that village of women, the village of community that shares stories, and talk about what is considered happy, healthy, who comes to stay with you, who helps you prepare meals, who helps to keep you off your feet in those first 3, 5, 6, 12 weeks, right? Because your body really needs time to recover from this huge experience of childbirth and pregnancy. And feelings of guilt and failure experienced as a result of a lowered libido. When we cannot satisfy ourselves or our partners, we feel guilty. We don't feel comfortable in our bodies. We have body image issues. We develop all sorts of things because we don't have the opportunity to communicate, to prevent, to entrust, and to help ourselves when it comes to these pelvic floor issues. I mentioned here the American Sexual Health Association because when you have questions about sexual health, you want to make sure you're going to the correct healthcare provider. And sexual health is not necessarily part of my scope of practice, but I certainly am comfortable to refer to other individuals who are qualified to have the discussion and to follow you through treatment with regards to sexual health. The Bahamas also has the Bahamas Sexual Rights Association, and they're doing their promotions here in the Bahamas. We also have the Crisis Center in the Bahamas for women who undergo domestic violence and abuse. So there are support agencies wherever you go. It's important to, as a community, connect with them and make these resources available and accessible to all, because you never know what people are going through. Many benefits to exercise during pregnancy. Take a moment to read through. Reduces lower back pain in the postpartum period. Strengthening of the pelvic floor. Just exercise consistent 3 to 5 times a week, 30 minutes of moderate exercise during pregnancy. You don't want to feel as if you're overexerting yourself or overheating, and it should be something that your body's already familiar doing. So if you were not a gymnast before pregnancy, please don't take up gymnastics during pregnancy, right? And I say that as a joke, but really it's about what you're comfortable doing. But consider, if you're thinking about having children, really start the process of getting into exercise and wellness and fitness so that your body gets used to the idea of how to carry a load, how to maintain support, what posture should feel, what good posture should feel like, and what it feels like to have a good night's sleep, because that's going to be few and far between after your child is born, but certainly reduces the risk of gestational diabetes and preeclampsia, and reduces the risk of excessive weight gain in pregnancy. We want to make sure we do not have obesity as a factor, because obesity increases morbidity and mortality in our pregnant population. Treatment and prevention strategies. I have just a few slides left, so it might just get a bit sparse at the end. Of course, evidence-based approach. There is more research supporting what we do as physical therapists. There's a world of research. And so you want to make sure you're going to a qualified, credentialed physical therapist, specifically in pelvic health, to discuss the issues you have about pelvic health. And we're going to talk about lifestyle modification, hydration, fiber intake, your daily habits. What are you doing that's creating or causing more dysfunction? What can you do to improve or reduce some of the issues you're going through? Workplace advocacy. Does your workplace support you exercising? Does it have a policy in place regarding wellness and health? Separate from the government initiatives when it comes to maternity care, does your workplace also advocate for you in having appropriate or adequate maternity time? Do you feel as if you have job security? Is exercise part of your regular routine? If not, then let's figure out a way to create a safe, effective program that you can follow that really blends into your everyday routine that you can maintain. throughout treatment, and then continue lifelong learning. And of course, medical intervention. These are the intervention techniques that physical therapists use for pelvic floor dysfunction. So conservative treatment includes physical therapy, and that's what we just talked about, dietary modification. Many times when we talk about urinary frequency, we're going to talk about hydration. If you're someone who has a coffee for breakfast, a coffee at 10 o'clock, a cup of tea at lunch, orange juice, followed by spicy food for dinner, you're probably going to have more issues with urinary frequency. Your bladder loves a low pH. It loves being neutral. It loves having just pure water. And if you are preventing your bladder from being happy, the bladder's going to say, well, I'd like to empty, please, as often as possible. So we're going to talk about some of those reasons why your body's presenting the way that it is. Vaginal pessaries are a way to support the pelvic organ prolapse. So instead of having surgery, many patients will also opt for non-surgical approach and use a pessary, which I used to phrase as a bra for your uterus or a bra for your bladder, because it really helps to support and lift and allows you to continue with your everyday activities. But depending on your manual dexterity for your patience and tolerance, it's very important to be able to manage a pessary, and that you have more discussions with your urogynecologist, your gynecologist, and there are other physical therapists who are specifically trained, as well as nurse practitioners, in starting the process of you using a vaginal pessary. And then, of course, pelvic floor muscle training. Providing aftercare after a difficult delivery. This sentence is really about advocating for early intervention, for screening, and educating women even after childbirth is never too late. What happens when you push against a contracted muscle? That should say contracted levator ani muscle, not elevator muscle. But you get the gist. When we think about, again, when the uterus is contracting, allowing the baby to descend, you want your pelvic floor levator muscles to relax to allow for easy evacuation. If because the mom has no idea about what her pelvic floor is capable of doing, or is completely disconnected to what contracting and relaxing is, or only feels stress and pain, is clenching her jaw and is bearing down, she's going to have a difficult time. And if the same female pregnant postpartum is going to have another child, then we want to make sure that we get education in there early, so that as she goes through the next few phases of postpartum recovery and eventually a second child, we want to make sure that she's well prepared for the next one. Physical therapy can include biofeedback, pelvic floor muscle relaxation training, rectal balloon training, which is where you learn and become more sensitized to how much bowel content there is, when you should be pushing, if at all, when you should be relaxing, and understanding the sensitivity related to the anal sphincter and what happens just above. So there are certain reflexes that should occur that sometimes we dampen those responses based on our habits to hold instead of going when we feel the urge to go. And that tends to be, for the people that I see, is always has to do with the work environment. I don't want to go at work. I'm not going to poop at work. I'm not pooping at work. So they wait all day, drive home. And in the meantime, their poor rectum is just filling and filling and filling. And so, they're kind of training their body to do something that really shouldn't be doing. Diaphragmatic breathing, stretching exercises, dilator training. Following, and this is the patient that Dr. Agwu mentioned, when you have radiation to the pelvic area, you can have radiation-induced fibrosis. You can have vaginal stenosis. And although the cancer has been treated, this person now has to deal with the survivorship of vaginal dryness, difficulty with intimacy, poor tolerance to any penetration. And so you have to relearn how to use this part of your body again, and that's where dilator training comes in. Birth preparation is also what we do to reduce the risk of tears and also reduce the fear of tearing. We teach patients how to do perineal stretching and gentle relaxation. Always encourage compliance with medical follow-up, especially for our patients who are high-risk pregnancy, preeclampsia, and the issues related to ICU stays. When they have issues with hypertension, you always want to monitor these patients in those first 6 to 8 weeks after discharge from the hospital, because those risks continue at home and they don't have anyone really watching over them at that point. Scar mobilization, if you have a C-section scar. Incisional care is also what physical therapists are trained and qualified to do. Vaginal moisturizers, and there are a range of moisturizers and lubricants you can use that are not estrogen-based, if that's the preference as well, and also if that's the communication you've had with your urogynecologist. And of course, the discussions about sexual health, mental health, and lactation resources. We are sort of a one-stop shop, and we know kind of where to direct you when you have your question. Finally, holistic and integrative care is really about connecting the dots. Pelvic health, exercise and wellness, mental health, and systemic support should all go hand in hand, because you should not feel like you're on an island. Yes, the pun is intended because I'm on an island. But the idea is that when you're having the issues related to pelvic floor dysfunction and you want to get better and you want to do the things to make yourself better, to be a constructive and purposeful person in society, you want the system to also support your decisions too, and say, well, where's the group support here? Healthcare professionals should drive early intervention. There's something called a pelvic floor distress inventory. It's a 20-question questionnaire, and it really highlights your understanding or your perception of, do you have urinary distress? Do you have symptoms of pelvic organ prolapse? Do you have issues related to constipation and rectocele? And just filling out the simple questionnaire and communicating this with your primary care physician can really drive the conversation. Say, I think there's something else going on. Can we now refer to physical therapy for pelvic health? And then, of course, integrated care and patient-centered care means you don't just look at someone's pelvis, you're also looking at, what's happening above and below. Are they someone who is an avid runner? Are they someone who is bound to a wheelchair? Is this someone who wants to reconnect with their spouse? There's lots of other things. And also, when we think about discharging patients from the hospital, do they have more than one child they have to care for? Do they have adequate support at home to allow them to be able to breastfeed and do all the things they need to do? Are there nursery resources that are affordable? What are the integrative care and alternative care therapies, which also include acupuncture and meditation, yoga, and self-care, because all of these components really make for a whole person. It's never just one body part. So with that in mind, we're thinking about sexual health counseling, mental health support, doula and lactation. I mean, doulas are pretty amazing. Honestly, I wish every woman could have a doula when going through pregnancy. It's just a wonderful support system. Antenatal education and postpartum care. It's never too late to do screening, and it's never too late for education, because we want our patients to be making informed decisions when they make decisions about exercise, about self-care, about how to lift, what to lift, body mechanics related to that, and what tools are appropriate for them, because there's a lot of information on the internet. And how can we guide our clients to make sure they're making well-informed decisions that are researched and backed by evidence? So at the 6-week follow-up, when most new moms will see their doctor, that's kind of the opportunity to talk about not just birth control, but how you are doing in terms of the perineal tear, fecal incontinence, being able to engage these muscles again. Nobody wants to really talk about intercourse, but it's important to say, I'm very afraid of the next step. What's really appropriate for me, and how can I get started with the right direction? But just being able to ask the question and bring up the concerns is very important, and not just let that 6-week follow-up kind of bulldoze you with information. For patients who are high-risk pregnancy, we talked about a little bit of this risk for mortality and morbidity, and monitoring these vital signs is so critical. So early referral to physical therapy at home is so important, and hopefully it's driving more of what we're doing in the medical sequela or protocols. Postpartum preeclampsia symptoms, which is this elevated blood pressure, which means that there's a high risk of rehospitalization, can persist up to 6 weeks after birth. So if a mom has been sent home and discharged, and then before that 6-week follow-up ends up with high blood pressure and ends up potentially with stroke symptoms, they're readmitted. There's no one in that 6-week period kind of monitoring them. So we do want to take, we want to be more diligent and take close care with our moms after that discharge period, and kind of check in on them a bit more consistently. Here's the research. Can send that to you if you need. And then questions I will open here, but just for your reference, the American Urogynecology Society offers fact sheets, services, information. They also fund the Voices for Pelvic Floor Dysfunction, which offer lots of information on understanding the vocabulary and the diagnoses. But we want to encourage everyone to be proactive about holistic care and explore treatment prevention with your pelvic health physical therapist. Thank you. Questions?
Oh, that was fantastic. Dr. Bonimy-Lee, I'm gonna start by saying that was really great. And I figured it would be that kind of thing where I could think about my patients, but full disclosure, I've had 2 kids myself. I'm plan my life around when there's a bathroom, right? So I'm sure there are many people, the chat is actually live. People are texting like, oh my God, she's talking to me. So really appreciate that. And so I had one quick question, and then I'd love to open up for others who have questions.
Okay.
I was intrigued about the leggings. And so asking for a friend, not me, how tight is too tight? And what do you, when as leggings and, yoga pants and all these things are in, like, what do you advise people when they're like, well, how tight is too tight? Thought I'd start with the easiest question.
That's a good question. So when we think about compression for patients with lymphedema, we're saying, okay, well, you want to make sure you can fit one finger underneath. You want to make sure there's not creating a tourniquet. And you want to make sure it's comfortable that you're wearing, that when you bend a joint, you're not feeling like you're constricting anything. So I will give the same guidelines when it comes to leggings and abdominal support. You want to make sure you can breathe in it. There shouldn't be a huge line where the elastic was that's kind of preventing or creating constriction. It shouldn't feel as if anything's being pushed down in the abdomen, and you should have active control of your abdomen as well. So look for those sort of lines where you have the indentation and you can see start swelling on both sides. That's too tight. It's too tight.
Maurice, maybe you can pull off the slide so we can see folks, because I can't see if people have a question or what have you. So we can maybe stop share, we can see folks. Another question I do have, you mentioned, I was going to ask, what is the best screening tool for a provider? Because I can tell you, I didn't learn about this in medical school. I don't know if they're now in having these in courses, but what would you suggest as a small or a quick screening tool to ask, since people may not bring this up? What do you suggest the questions that kind of, if these answers are correct, someone is having those issues?
Well, the pelvic floor distress inventory is a 20-question one. So questions would be like, do you notice heaviness within the abdomen? Are you noticing you have to push on the perineum in order to evacuate for a bowel movement? Do you go to the bathroom frequently? And these questions are quite open-ended, but at least starts the idea, and you end up with a score at the end. And it tells you, if you have a high percentage, it means that you consider this to be very distressing. You yourself consider this to be an issue. And that's enough for you to say to your provider, hey, can we explore this a bit more? Because this is happening. Are you noticing leakage? So there are about 6 or 8 questions for each section, and it adds up to 20 points. And so, not 20 points, but there are 20 questions. And so you really just calculate, and it gives a very sort of basic understanding of what your client is going through.
And I guess the other question I had, and taking moderator's privilege and asking all of this, but when you're looking for, let's say you take that distress tool and you say, okay, my patient has the concern for pelvic floor disorder. What do you recommend that they do in terms of looking for a pelvic floor therapist? What are the criteria you're looking for? What are the credentials you're looking for? Maybe you can share.
Yes. So the American Physical Therapy Association has an entire section for pelvic health. And so they have a website for the pelvic health section, the Academy of Pelvic Health, where you can look on the PT locator. And I had it up on the last slide, I'm so sorry. But the PT locator allows you to put your zip code in, and it will show you within 5 miles, 10 miles, 25 miles of your zip code to find a qualified registered pelvic health physical therapist. In addition, if you don't have access to the PT locator, you're looking for the credentials of physical therapists. That could be MSPT or DPT. You're also looking for WCS, which means that they're board certified in women's health. You can also look for different credentials, which I think there's one that's PRPC, which means they've gone through a different credential, but you want to look at the credentials and you also want to see that the license is displayed in their office. You can also ask them, you know, where did you receive your training? And you can look up this information because they should all be consistent with what is regulated for that state, right?
Well, others have questions. I've taken the first three. Anybody want to unmute, and then I have one more for other people. Any others with questions?
So I wanted to talk about lubricants. I love that. So there are lots of moisturizers that are out there, but you want to make sure that you choose something that has very low alcohol content, because of course alcohol creates drying. And if there's fragrance, that also means there's alcohol, which also causes drying. If you have an issue with vaginal dryness, you do not want something that's going to cause more drying. So there are some products out there. Olive & Bee is literally olive oil and beeswax. It's made by an Australian company. Reverie is also a popular brand. Good Clean Love. Yes, Replens you may also see in Walmart or CVS. You may also see it here at the Friendly Pharmacy. Uberlube and different vulvar bombs. So always try and take a look at the back of the product or try and do a little bit more research in terms of what the actual contents are. You want few contents. You don't want it to be filled with silicone and that sort of thing. But you want to make sure that you're using something that's going to be okay with your body and maybe hyaluronic base moisturizer.
That is all I have. I don't see any questions. I think we will send out the slides, which are filled with a lot of great information. Thank you so much for that, Dr. Bonimy-Lee. That was really in an infrequent conversation, but clearly by the data that you presented, one that we need to be having much more often because it's impacting our lives, our patients' lives, and the like. Thank you so much for your time, your expertise, and everybody enjoy the rest of your day. Thank you so much, Dr. Bonimy-Lee. Bye, everybody.
Thank you.